Question 117, how are you going to fix this one? So, intramedullary fixation, syndesmotic screws, a locked semitubular plate, an unlocked semitubular plate, or interfrag screws only. Now this one should be pretty much a layup. But let's talk about this particular fracture. So first of all, hopefully you see that posterior malleolus. Some people chase that. I actually probably would chase that. Probably put screws and maybe a tension band on the median mal, but you're definitely going to be putting a locked plate on that fibula. It's going to be much more rigid. The article that they're looking at is Tornetta. So the correct answer for this one is a locking semitubular plate number 3. Question 130, you have x-rays of a 57-year-old female who had a chronic draining ankle wound after a total ankle 3 years ago. Big wound dehiscence, 2 incision and drainage, IV antibiotics. She's currently without fever and chills. Here are her x-rays. So what do you do with this one? Okay, so let's get rid of some of the answers that we could start to eliminate. I think we could probably take a single-staged replant. This thing's infected. We know it's infected, and I think the hindfoot arthrodesis part is just it should clue you in that that's not the correct answer. We'll look at the next one. I think we can safely eliminate polyethylene exchange. That would be what you would do for an acute infection, like you would do in a total knee poly exchange for a total ankle, same principle. And then I think finally we could probably eliminate incision and drainage. Fool me once, shame on you. Fool me twice. Well, I'm not going to get fooled again. So basically now you've got staged total ankle and a staged ankle arthrodesis. Now, I think we probably would all agree that a staged total ankle is not an option. The key here is you got to get rid of the infection. So you're probably taking this out, probably putting a spacer in, probably waiting for the infection to clear, and then you're praying. The reason you wouldn't do a total ankle, if you look at the talus, it almost looks like the talar component is subsiding and it's going to cut out. Maybe that's one of the reasons the hindfoot arthrodesis, they were thinking about that on response number 4. Anyway, it almost looks like she has an in-bone done on her tibial component. There's a lot of tibial lucency noted there. I don't know if that's a cyst or an old in-bone. Either way, you're not gonna do a total ankle on this one. You're gonna try to clear the infection with antibiotic spacer, come back in, put a big femoral head allograft, probably put a hindfoot nail. Real big disaster, real tough case. So treatment, the correct answer is response 3, staged ankle arthrodesis, structural allograft. Question 158, 23-year-old male running barefoot felt acute pain on the plantar aspect of the foot. Examination reveals ecchymosis and pain plantarly. And the initial treatment should be cast immobilization, a steroid injection, supervised physical therapy, an eccentric stretching program, or an orthotic. Here are the images for this particular question. Okay, so now we're going to look at, back to the question itself, what to do. So I think we can all agree that corticosteroid injections and eccentric stretching program, physical therapy, that's all for chronic plantar fasciitis. So the question comes down to, this is an acute injury. He had a ecchymosis, acute problem. Do you put him in an orthotic or you do cast immobilization? And the correct answer is cast immobilization. This is an acute treatment. The surgical management for this is conversely a plantar fascial release, which never makes real sense, but that's probably what you do long term if you had continued plantar fasciitis. Anyway, the correct answer is 1. Questions 2, 3, 4, and 5, they're all sort of on the chronic plantar fascial end of things. Question 147, 28-year-old female, 6-month ankle sprain that won't get better. Had it 6 weeks, but recurred 2 months ago. No real giving way, but lacks confidence in her ankle. Pain worse on uneven ground. Tenderness over the fibula, resisted eversion of the foot, the posterolateral aspect of the fibula, I should say, tenderness. No laxity of the lateral ligaments. So the treatment could be ankle ligament repair, peroneal tendon repair, osteochondral lesion excision, or a scope and a debridement. Take a look at the imaging. And we'll start talking about the answers. So this is a classic example of the in-training exam giving you about 1,000 different images and trying to confuse you, when in reality all you need is the question itself, and you can figure it out. So pain on uneven ground, that's a subtalar joint, and the peroneal tendons are responsible for that. Posterolateral aspect of the fibula, resisted eversion. These are all peroneal tendon problems. So we can effectively eliminate ankle ligament repair. They're trying to get you caught on making you think there's an OCD there, but there's not on the MRI. So I think you can successfully eliminate 3 and 4. And an ankle scope, that's just, they're trying to confuse you. This is a straightforward peroneal tendon repair. If you look on the MRI, you can maybe see perhaps a split tear on the brevis. Maybe. Hard to say. Anyway, correct answer on this one. Question, response number 2, peroneal tendon repair. Question 182 will drive you crazy if you're in practice. It's what to do with that very subtle ankle fracture x-ray. So take a look right here. We have an ankle fracture. You can see the fibula. So the question would be, what do you do about it? So you've got open reduction, internal fixation, manual stress with internal rotation, gravity stress with external rotation, palpation just by physical exam, and closed reduction with Quigley traction. Take a look at the answers that you think are going to be the correct one. Okay, so this is one that's a good teaching case. Now, I think we can eliminate some of the answers pretty quickly. Closed reduction followed by Quigley traction. Unless you're Michelle Sugi at USC, you probably don't even know what that is. So I think we can safely eliminate that one. Palpation on the medial soft tissues, reasonable to do. You've got open reduction, internal fixation, and then the stresses. Well, it's an external rotation. It's an SCR ankle fracture, so probably manual stressing with internal rotation is not going to do it. So now you're left with open reduction, internal fixation, and gravity external rotation stress. Now, what I tell you what I do and what I tell you the correct answer are different. So if you look at the medial clear space, you can kind of see it's wide, but it's not a slam dunk. And the correct answer is gravity external rotation stress view. And they want you, question 3. With that said, I kind of know that I'm going to fix this one. I still agree with the answer, but if you look at what I call the lateral incisura line, so that's the incisura and the lateral edge of the talus, that thing is clearly off. clearly. That's an easy call for an open reduction internal fixation, and I'm definitely going to fix this. But the correct answer is gravity external rotation stress. We place the patient's leg and let gravity do the external rotation stress for you. And that's a JBJS article, very good article. Question 200, 36-year-old former professional baseball player felt a pop in his Achilles tendon while playing softball. He had a previous history of chronic tendinitis when he played. He had multiple steroid injections. He's got a positive Thompson test and plantar flexion weakness. Take a look at the answers. You've got a percutaneous minimally invasive like an Achilon, a calcostectomy and insertional repair, open debridement and fascial turndown, non-surgical treatment with functional rehab, and mid-substance debridement and FHL tendon transfer. Here are the images. You can see the Achilles tendon rupture. So the question would be, what are you going to do? So I love this question. I think this is a completely fair question, and it talks about a lot of things you need to do with Achilles tendon ruptures. First thing is, as a routine, I actually get an x-ray to make sure there's not calcium in here, because you could get burned on this one for sure. Acute injury 2 days ago, softball, classic sort of weekend warrior thing. You know, it's very, very reasonable to think that this is an acute rupture, but it's not. It's a chronic one. And if you have calcium in that tendon on the x-ray, you know that it's not an acute thing. So I think you can safely take away the acute stuff, the non-surgical treatment and the Achilon, and take that away. Open debridement, fascial turndown sounds pretty cool, might do it. Oh, I heard about a guy who did it, but that's not the answer, and they're trying to trick you. So finally, you get down to two reasonable things to look at for an answer. Now, this is not a mid-substance problem. It's an insertional problem. It's an insertional rupture, and the treatment for this is at least a calcostectomy and a 4-row repair. Now, the reason number 5 is not right is because of the mid-substance debridement, but the FHL tendon transfer part of it is actually reasonable, and actually for this guy I would probably have that on the consent. It's not entirely possible that you're going to pull down this section down to the heel and make this gap up. It's going to be a big stretch. So having an FHL tendon transfer as a bailout, put it in with an interference screw, is something I would be planning for, would be on the consent. But the reason that question 5 is not correct is because the mid-substance portion of this. Great question. Really take a look at this one. Correct response is 2, calcostectomy and repair. Question 211, 52-year-old woman with big toe pain. Pain over the medial eminence, pain with range of motion. X-rays demonstrate the following. So what's the best choice? Chylectomy with Moberg, a joint fusion, a chevron with a chylectomy, or an implant arthroplasty? So I love the question. I hate the citation, and I'll tell you why. But anyway, so you've got a grade 3 hallux rigidus. This is a big, pretty bad joint space narrowing. Lydia Lee and I are putting out a paper talking about how to quantify that. Maybe a very minimal bunion. I think that's why they're trying to get you with the chevron. But clearly, response 4, chevron is not the answer. So then you got chylectomy, Moberg, and fusion. I think we can eliminate question 5 or response 5, implant arthroplasty, particularly if it's silicone. Never, ever, 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 ever silicone. So that's always the wrong answer. Always, always, always. So basically you've got the 3 treatment choices, 1, 2, and 3, for essentially stage 1, 2, and 3 hallux rigidus. So for stage 1, we would do a chilectomy, knock off the lip. For stage 2, where the joint surface isn't too bad, you could knock off the lip and do a Moberg, which is a dorsiflexion metatarsal osteotomy. And then for 3, you would do a fusion. Now, a fusion, that's the correct answer. That's the one they're trying to go for. A fusion for a lady, that's not a benign surgery. So you're definitely going to have this discussion. No high heel shoes ever, or if it's so, it's going to be very limited. The reason this question drives me absolutely crazy is for 2 reasons. Marty O'Malley and Jonathan Deland's paper in JBJS is a really good paper. And it was something that I did with Dr. Hamilton in '96. We looked exactly at that paper, what they did, talking about the different treatment choices. Now, in their conclusion, they looked at stage 3 hallux rigidus, and they said that a chilectomy and a proximal phalanx osteotomy was actually a viable option. So it goes to show that they're misquoting it, and they're giving you the wrong answer. So if you read the article and knew the article they were citing, you would actually get the wrong answer, which drives me crazy. The standard answer for grade 3 is going to be a fusion, but again, definitely warn those women about their shoes. Question 216, 28-year-old man seen 3 days after falling down a flight of stairs. Which intervention or technical consideration is most important to maximizing functional outcome? 1, suture button device. 2, deltoid ligament repair. 3, quadricortical syndesmotic screws. 4, open reduction internal fixation, open reduction of the syndesmosis. And then 5, ankle and neutral for implant placement. So this is a question probably targeted towards more the junior resident, because I think they might take their experience and place it and do the wrong answer. So when you have 2 choices that are opposing technical implants, often they offset, so you can kind of eliminate those. I think junior resident might say, well, you know, the deltoid ligament looks bad, let me repair that. That's also not the right answer. And this leaves you basically with getting the syndesmosis right or getting the ankle in neutral. And I think the lateral x-ray might try to trick you into that. Now, the first thing with this one is to get a tib fib and look at the proximal tibia, because you're going to struggle with length, alignment, and rotation. I also think that there probably is a posterior malleolus on the lateral aspect. But I think the pretty clear-cut answer is for open reduction of the syndesmosis.